Yeah. Uh, Hi. Can we start now, ma'am?
Sure.
Yeah. Thank you. Firstly, very good morning to all. Today we are into the microbiology topics. This is a basic module 2, antimicrobial stewardship, that is organized by FCPI. I also want to introduce the speaker for this today's session is Dr. Aruna Pujari ma'am. Currently, she is working in Bridge Candy Hospital that is located in Mumbai, and she is an HOD of in charge of infection control committee, and followed by she is an having a many appreciations under her name. Firstly, ma'am has 64 international and national peer-reviewed publications and also 3 book chapters. And also, ma'am have more than 10 years of experience in this AMS and IPC domain. And now, today, the topic is regarding preparation and understanding of antibiogram. So, without any late, I want to hand over the session to Dr. Aruna Pujari, ma'am. Ma'am, the stage is yours. Please go ahead.
Thank you, Satya, for that kind introduction. And at the outset, I'd like to thank Federation of Clinical Pharmacists in India for giving me an opportunity to share some of our practical, meaning practice related issues that as a microbiologist we do on an annual basis. And it's good to be collaborating like this because we learn and understand from each other. So today's topic that I'm going to be taking is preparing and understanding antibiograms. And I think this is one of the very important pillars and the low hanging fruits of antimicrobial stewardship programs globally. So we know that antimicrobial resistance is on a rise. We know that it has devastating effects on human lives as well as economies, and that's been, well publicized, written down. And unless we do something about it, we know that it is going to be a disaster. We are already in that pandemic of antimicrobial resistance. And we need to, take small steps to move ahead and work around this very important problem. And that's one reason why probably we are also here gathering, trying to understand how, in our own ways, taking little steps, we are going to, support this prevention of antimicrobial resistance. So I'm sure that all of you all have read the Grams report of 2019, a recent publication actually in Lancet in 2022, which said that AMR is at least as large a problem as HIV and malaria, maybe even much larger. And they found that in 2019, 1.27 million deaths were directly attributable to antimicrobial resistance. So it's now globally recognized as a problem. I believe yesterday or day before it was also discussed in the UNGA meeting, and so we really recognize it as an important issue. And why are we really recognizing this as an important issue? And it is because antibiotics, unlike other drugs, do not only affect that patient who is taking that antimicrobial agent, but also compromises its efficacy on another patient. We know from various studies that it causes mortality and it causes excess of costs, whether it's due to length of stay, whether interventions, and so on, particularly when there are MDR and XDR organisms that are isolated. At least 30% of hospitalized patients receive unnecessary and suboptimal antibiotics. This can be more. 5% of patients experience adverse reactions. So apart from antimicrobial resistance, antimicrobial agents are associated with plenty of adverse reactions, also drug-to-drug interactions. So, and a whole lot of money gets spent on unnecessary antibiotic prescriptions. And one of the most common disease syndromes is upper respiratory tract infections, which we know predominantly is caused by viruses, and yet people end up taking antimicrobial agents. And about 50 to 80% of outpatient antibiotics we know is also inappropriate. Now, with all of this in the background, WHO in 2017 made these statements that antibiotics should be viewed as a limited resource. Antimicrobial resistance is a critical patient safety issue, and that antimicrobial resistance is actually a public health threat. So how do we preserve our antibiotics is with the help of an antimicrobial stewardship program, where both you, me, and a physician, along with a set of other team members, are involved in working towards improving the use of antimicrobial agents. Now, when talking about an antimicrobial stewardship policy, antimicrobial stewardship program, and antibiotic policy is one of the key pillars that an institution should have, so that it will help in identifying antibiotics which should be given to a patient when you don't know what the organisms are. So for this antibiotic policy, naturally, a lot of work goes on by parallel teams. There is risk stratification done at the end of the bedside, where the clinicians are involved. There is the antibiogram preparation and information education communication about antibiograms, which is probably done by the microbiology team. Auditing for compliance, feedback, and identifying research priorities are all is a part and parcel which is of activities which will be undertaken by the pharmacy team or the clinical pharmacist team, as well as the antimicrobial management team. So a lot of coordinated efforts need to be done when we are talking about compliance to preparing an antibiotic policy and complying to an antibiotic policy. And probably this is one of the what we are doing today is one such session wherein we are talking to each other about antibiograms and how they can be used better. So it's an IEC activity that really we are doing. So moving on to some more clarification of what really is an antibiogram. So basically the terminology is cumulative AST data, and the first publication of cumulative AST data of how it should really be done from the microbiology laboratory was in 2000. And this is driven by the Clinical Laboratory Standards Institute in USA, which gives us guidelines for analysis and presentation of this cumulative AST data. So what is really cumulative AST data is basically you are taking the drug susceptibility pattern of susceptible isolates over a defined period of time to reflect the percentage of susceptible isolates of a particular species or organism to each of the antimicrobial agents that are tested. Okay, and this data report that gets generated can be called as either a routine or an enhanced antibiogram, and they can be presented in various formats, whether it could be graphical, it could be tabulated, and so on. And the term cumulative antibiogram actually has been eliminated now. There was a revision in this M39 document. We have the fifth edition now available in 2023, which has clearly said that this cumulative antibiogram, that word has now been eliminated. You call it just an antibiogram. And this cumulative AST data report, basically, this cumulative susceptibility, antimicrobial susceptibility data report can be classified into one, a routine antibiogram. What is the function of the routine antibiogram? It guides clinicians in selecting empirical antibiotic therapy for initial infections when definitive susceptibility results are not available. Okay, that's what also our, the aim of our antibiotic policy is. And it also includes other reports that do not meet this criteria of a routine antibiogram. So you could have, you could prepare other reports with the aim of identifying emerging resistant patterns or rare phenotypes, identifying, assessing susceptibility profiles of all the isolates in the database. And I will show you some examples. Trending antimicrobial resistance for public health initiatives. So which is the most common antimicrobial resistant pattern if in India I have to find out from the perspective of public health initiatives, or if I were to take what is the susceptibility pattern in India for salmonella, and we find that okay, quinolone resistance is very common, or third generation cephalosporin is very common, then what other public health initiatives can be taken in order to actually reduce the disease rather than only focusing on the treatment or management perspective? Maybe we could add vaccination to the as a public health initiative, and so on. So understand, when your questions are more specific than simply empiric therapy, then it will it can still be classified as cumulative susceptibility test data report, but it is not becoming an antibiogram, okay? Not becoming a routine antibiogram. Okay, so this is the document which we use in the microbiology laboratory to prepare a cumulative antimicrobial susceptibility test data report format. So where do you really capture this information from? So we are starting from the basic. We've done, what is the definition, or what are the different types of such data reports, and from where would you get them? So the M39 guidance mentions it could be taken from the AST instrument. For example, I will give you an example of how we do it. We are doing it from our Vitek. We capture this data from the Vitek itself, because remember that for an antibiogram, you should not suppress any agents. Whatever is tested should be reported, should be captured in the antibiogram. Unlike in a patient's report, we would suppress. For example, if it were MSSA, I would suppress vancomycin, I would suppress teicoplanin. But if I were to do an antibiogram preparation for MSSA, then I would still capture vancomycin and teicoplanin. So we can take it directly from the instrument, and there are certain advantages and disadvantages coming from taking directly from the instrument, and most of us do this. I've been doing it for now close to more than 15 years, and it is done from the Vitek itself, either manually, or you can through an Excel sheet, or through a software, which I will show you in the subsequent slides. Then you can also do it from the LIS, okay? That is your laboratory information system. Now, what happens from experience, I can tell you from the LIS, basically, there we do many a times we do cascade reporting. So an antibiogram, we should ensure that if you were taking data from the LIS, that kind of the suppression of antimicrobial agents that we normally do for patient reports should not get suppressed in this. That information should get captured. Or if you have an EHR, electronic health record, or a clinical decision support system in your hospital, from there also you could actually capture information. Maybe later on, when we are discussing this issue, we can find out as to from where other people, some of your colleagues are capturing information. But as far as I know, most of us would capture information from the AST instrument itself. Okay, so now coming to the different types of antibiogram. So we have a routine antibiogram, which is basically a report that gets generated from the analysis of collective AST results, usually from a single healthcare facility with the help of the M39 guidance. Now we'll go to that also. What is the real M39 guidance? So basically here, what is a routine antibiogram? You are taking for a particular defined period, let's say 1 year. Ideally, NABH recommends that we prepare an empiric policy annually. So you can take data for 1 year and then tabulate that data across antibiotics and the various organisms, and that becomes your routine antibiogram. So what is an enhanced antibiogram? An enhanced antibiogram is again percentage susceptibility data that gets stratified using specific parameters. For example, it could be specimen source specific, or it could be patient location based, for example, or it could be multi-facility based aggregate data. So an example would be, let's say, ICU respiratory samples, lower respiratory samples, or ICU blood cultures, or OPD stool samples, okay, or OPD blood culture. So that becomes an enhanced antibiogram. So this is an example of a routine antibiogram. So here, as I mentioned, this is your organism list. These are all gram negative. So you could have a gram negative and a gram positive. And this is the number of strains. And here are the various antibiotics. And these numbers are in terms of percentage susceptible. Okay. So the routine antibiogram, as we've earlier also seen, is used for selection of empiric antimicrobial therapy for individual patients. It is used for development of the empiric antimicrobial treatment guidelines or algorithms based on infection type. And it is also used for decisions regarding the antimicrobial formulary. Okay, so that's the utility of your routine antibiograms. And this is an example of a routine antibiogram from my setting, where as you see here, this is Jan 24 to June 24. And if you see here, these are the organisms which are the most common. What I have done is I have selected more than 30 organisms, because that's part of the M39 guidance, that you should identify, you should take only the first isolates. These should be clinical isolates. They should be at least 30 in number. There should be no surveillance related isolates. So these are some of the guidelines of the M39. So as you see here, we had 559 E. coli, 172 Kleb, Proteus 32, and Pseudo 101. And these are the different antibiotics that they are, susceptible or whatever. Percentage susceptibility is noted over here. And this can actually be for us downloaded on an Excel sheet and then accordingly tweaked as well, and put in ascending or descending order. These are from all different types of specimens. So I have, the filter does not contain specimen. This is simply a routine antibiogram of gram-negative bacilli from my institution between Jan to June 24. Okay, if anybody has any questions with regards to any of these, please keep on writing. We'll discuss it later on with the pictures also. Now, this is similarly a routine antibiogram in my setting for gram-positive organisms. And these are the organisms which were more than 30 in number, according to the M39 guidance. So I have Staph aureus 76, coagulase negative Staph 37, and Enterococcus faecium 43. And if you look at Staph aureus, here, oxacillin is about 60, oxacillin susceptibility. So since these are all susceptible data, oxacillin susceptibility is about 61.8%. That means if it is 62%, then the rest 38% are actually MRSAs. Okay, so this is how a routine antibiogram looks. I will explain the color scheme, etc. also to you in the subsequent slides. So I've shown you antibiogram data, a routine antibiogram of gram negatives in my institution and gram positives in my institution. Okay, what is an enhanced antibiogram? An enhanced antibiogram assists with more targeted empiric therapy based on the infection type, the patient type, the organism isolate source, patient location, etc. So this could include examples of GNB antibiograms in inpatients, ICU patients, burns patients, outpatients. I just gave a few examples in the previous slides as well. Or it could be urinary tract isolate antibiograms in different patient locations, or blood isolate antibiograms in different patient locations. It could also be organism specific, for example, Streptococcus pneumoniae antibiograms for community acquired pneumonia or meningitis, or Staph aureus antibiograms in different patient locations. And the antimicrobial agent combinations also can be done to indicate increased coverage with the combination. This is something that we don't often use, but probably we should start using. As of now, most of us are actually doing very simple antibiograms, and the combination antibiograms we're really not doing. But this may be a good thing to do, particularly when we are experiencing so many drug resistant organisms. So this is a kind of enhanced antibiogram of ICU of urinary tract isolates. Again, if you look at the duration, it is 1st Jan to 31st August. And here again, if you see, E. coli is 35. So frankly speaking, if I were to call this as an antibiogram, then I should only include E. coli, because that number is more than 30. So no other organism is really qualifying for more than 30 here. As you see, the Klebsiella is about 12. Now, one very important issue over here can be, and which also M39 talks about, is data validation. So this is all data which is captured one from the VITEC, and then besides that, you need to add information depending upon the admission, where is the patient located, the clinical details of the patient, and so on and so forth. So if that data doesn't get that data should get validated by more members of the team. If that doesn't happen, there may be wrong entries, which again I will show you examples, which need to be cleaned subsequently in order to get accurate information. Okay, so this is another example of IPD urine samples for the same duration. As you see here, what qualifies is E. coli and Klebsiella. These are more than 30, and as you see, in fact, if you see the patterns, let's look at this E. coli. This is from ICU, and if we were to look at where is imipenem and meropenem, here is meropenem. Imipenem and meropenem are close to, meaning if we take 80% susceptible in the ICU. Okay, but what happens in the IPD? In the IPD, imipenem and meropenem are a little bit more susceptible over here. But if you look at Klebsiella over here, Klebsiella is close to, meaning more than half of the Klebsiella in the in IPD are resistant, and similarly, even in the ICU, more than half of them are actually resistant. So while this does not really classify for an antibiogram at this moment in time, because it is less than 30 in number, but what I can do to solve this problem is I can extend the date beyond Jan. So it is suggested that, what's very important is you need to have 30 isolates. So if you're not getting 30 isolates within a period of a year, then you can extend yourself to, months behind. And but very important to get 30 isolates. Okay, so here in this diagram, it's basically only E. coli antibiogram coming in the ICU, not really Klebsiella. If I were to increase, or I will, at the end of the year, I will prepare this, I will get the, I think I will get the number 30. Plus, when I'm screening data, I might actually have increase in these numbers. Okay. So we also mentioned about, organism-specific enhanced antibiograms. This is for Streptococcus pneumoniae, for community-acquired pneumonia or meningitis. And as you see here, important, we all know that CLSI gives different breakpoints for strep pneumoniae being a pathogen in the CNS, and strep pneumoniae being extra CNS. Okay, so therefore here, as you see, you have one row where all the different antibiotics for strep pneumonia have been charted, and the other row where the isolates have been segregated to meningitis and non-meningitis. Okay, and the typical difference is usually with penicillins and cephalosporins, third generation cephalosporins, where the breakpoints of the CNS isolates are much lower, and therefore you have more resistance versus the non-CNS isolates. Okay, so if you get a good number of Streptococcus pneumoniae in your institution for in 1 year, to make it 30, you could have 1 year. Otherwise, you will need to go back to maybe 2 years, 3 years, 4 years, whatever number of years is required for you to make that isolate number, the number of strains here, to 30. Only then can you project an antibiogram and then segregate these to this meningitis and non-meningitis. Okay, what about Staphylococcus aureus? So that's also similar. Here you have all aureus over here. Then you can classify that into MRSA and MSSA. Again, very important that you get the isolate number as 30. So if you want to, if you don't get that 30 in 1 year, 1.5 year, you go back into data. And as you see here, we may not be using rifampicin very frequently. It's used for only in certain conditions, that too as combination therapy. But the M39 document mentions clearly that you need to get all suppressed antibiotics also onto your antibiogram, and that is how it is mentioned over here. It is getting captured over here. And another important aspect of data validation over here could be, if you have oxacillin can serve as a point for data validation. You have 68% of your oxacillin isolate being susceptible, which means that around 32% will be MRSA. So you need to ensure that there is no oxacillin susceptible over here. Okay, and in MSSA it has to be 100% oxacillin susceptible. So that's how you can have organism specific. So you can have salmonella specific, can have shigella specific, because these are organisms which cause specific disease, and they also have public health public health related perspectives which need to be taken into consideration. Okay, now coming to color coding, we've seen these colored graphs a couple of slides earlier also. So charts a couple of slides earlier also. So this is Yeah, what is the meaning of all these colors of green and a little orangish and yellow? This is again given by the suggested by the M39 guidance, where they say that anything that is less than 60% would be colored in this color. Yellow is basically 60 to 80%, and green is more than 80%. So when you're looking at any antibiogram, and you need to identify all the drugs that are actually more than 80%, the green ones. Okay, so this pictorial representation becomes much more easier to capture. So the more than 80% one should be actually used as, should be your options for therapy when it comes to empiric therapy. But can you use all of them for all diseases? No, because you need to understand, meaning you need to know what is the site of infection and whether your drug is really reaching there. And that's basically the area where the clinical pharmacist team plays a very important role. You all support us with what drug concentrates where, whether any dose modifications need to be done with this drug and with different drugs to prevent adverse events, or to prevent the cross reactions, whether there are any devices which will have biofilms and we need to do something about those devices. So all of these factors, the other factors also need to be taken into consideration whenever you are picking up the more than 80% ones, for as options to therapy for treatment. A classical example could be, let's say you have 90% susceptibility to of E. coli to tigecycline in a urine antibiogram. Can we use that tigecycline for urinary tract infections? No, because it doesn't concentrate in the urine. So uh, uh, just the antibiogram is not going to be sufficient when you are drawing out a policy. It will also take into consideration many other aspects where the clinician, the clinical pharmacist, as well as the microbiologists are going to be involved in deciding what could be good empiric therapy options for any particular disease. Okay, so the M39 also mentions about how this could actually guide for empiric therapy of initial infections. So where routine antibiograms could be used, whether gram positive or gram negative. And then enhanced antibiogram, we already saw it could be, in whichever areas depending upon your own institution. So drugs which have 90 to 95% susceptibility, the green ones, okay, they should be used ideally for critical cases, of course keeping in mind all the other things of concentration and other things. So ideally they should be used for critical cases. The ones with 80 to 85% should be used when there is lower risk of mortality in 24 to 48 hours. And you could also use drugs which you could include drugs with intermediate susceptibility and an eye carrot, particularly for urine, when you don't have the risk of mortality. So that's also mentioned. So how does this go about? I can give you an example. A patient comes to my emergency department. This is an 85-year-old. This is a very common scenario to us. 85-year-old gentleman who has fever for the last 2 or 3 days and has become drowsy, presents to the emergency services, and he's also hypotensive, and whatever all the other features of sepsis and septic shock are setting in. Now in this situation we know that this is a critical case, and we've also, based on examination, we have found that this patient has had previous history of recurrent urinary tract infection, so that becomes our primary um, differential. Now in this setting, this is an elderly patient. This patient has previous history of urinary tract infections, and now is setting into septic shock, which we know has higher mortality. Based on your empiric guidelines for urinary tract infections, in this kind of a patient, you would maybe select whatever is there. For us, in such situations, it is going to be a carbapenem. Okay, so in critical cases, it will be the highest susceptibility ones, and in where there is lower risk of mortality. If this patient had simply kind of, walked in with someone and was otherwise okay, not drowsy, simply some fever and some discomfort in the abdomen, we would have probably selected other agents. So that's how basically it can help in identifying empiric therapy for initial infections where we do not have the organism, but we, based upon our epidemiology, we know what are the typical organisms that we would encounter. So if you see here, this is our OPD blood culture antibiogram for gram negatives, and typically E. coli seems to stand out. Again, if I were to call this as an antibiogram, I would actually be wrong because I don't have 30 isolates for this duration. But this gives me a very quick idea of which is my most common pathogen. So I know that in OPD blood cultures, it is E. coli, and the most important source for E. coli is naturally the urinary tract. Another data validation point here would be Shigella species. It's very, very rare. In probably last 20 years, I've seen just one Shigella in the blood culture, and probably this is not the one. So I need to go back and check whether it has been erroneously marked as blood culture and instead of a stool culture. Okay, so that's how validation needs to be done whenever you come across any similar kind of query issues. This is our IPD blood culture, as you see. Here again, I can't call it as an antibiogram. It's not satisfying the criteria of 30. And yet I know that E. coli is the most common pathogen. This is for ICU and IPD together because, if I would have segregated this as ICU, I would have got lesser numbers. And secondly, that, meaning at this moment in time, I didn't want to go beyond Jan. But ultimately, when I draw my antibiogram towards the end of the year, I will actually have to probably go maybe 1.5 years back, about another half a year back from Jan 24 to get the 30 numbers and to identify which are the first few organisms. Now, based upon this, and in addition to the risk stratification, which I'm sure all of you know, what is the source of infection, and to know whether it is community or hospital acquired. Based on all of this information and this kind of risk stratification, one is going to identify what are you going to really give. So if it's a community acquired type 1 patient, then this is what we tend to give. That is a BL-BLI. Whereas if it is type 2, still we stick on to the BL-BLI with or without amikacin. MRSA is not very common in our setting. But if it's a type 3 patient, like for example, the one that I mentioned, it could either be imipenem, meropenem, but if it is healthcare associated, that is inside the hospital, particularly in the ICU, then we know that for us, it is mainly Klebsiella, which is the pathogen, and these Klebsiella are usually NDM producers. So this could be the combination. And the fourth type we all know is basically predisposing towards a fungal etiology, where echinocandins remain the choice, especially if there is shock features setting in, and if no azoles patient has not been exposed to azoles. So M39 also recommends preparing antibiograms for yeast, and which we have actually started doing. And here again, you might have to go beyond your 1 year to get good number of data of 30 isolates. And then once you start on empiric therapy, subsequently continuation of therapy would be based upon the susceptibility report, and also naturally based upon the patient's clinical status, because the clinical status will finally decide whether or not you are going to de-escalate or escalate. Okay, what does M39 say about using antibiograms to guide empiric therapy when the causative organism is there, but you don't know the susceptibility? Okay, so this is like the scenario would be the same. Let's take the same patient who's come to our emergency services. Blood culture was sent. On day 2, the blood culture is flagged positive. I know that there is a gram-negative bacillus, which is motile, that I can see in the blood culture. Now, I'm pretty sure that this is going to be E. coli because that's the most common pathogen that we have. But I do not have the susceptibility in hand, but I know the organism. So in that kind of situation, they say that you have to select based upon the most causative organism, which is there for that particular infection type. So if it is, as I mentioned, if it is urinary tract, it is going to be E. coli. And then look at the routine or enhanced antibiogram that is available within that facility. Okay. So these are some of the new issues that have been taken up by the recent edition of M39. So as I mentioned, it has refined definitions of cumulative AST data report and antibiogram. So that cumulative antibiogram has been removed and it's just antibiogram. And the cumulative AST data report comprises of your routine antibiograms and enhanced antibiograms plus your other kind of data reports, which you prepare based upon very specific questions. Then it also looks at practical concerns, advantages and disadvantages of extracting data from various sources. I've already mentioned that. Combines rapid diagnostics and resistant markers. This is new, and I'm going to share a slide with you on this. Then developing antibiograms for yeasts and antifungal agents for long-term care facilities. This is not a big problem here in India. But definitely in the US it is. Veterinary practices, this is again something which probably is less common here in India. Developing multi-facility antibiograms, developing antibiograms, how you use antibiograms for a stewardship program, preparing cumulative AST data reports for peer-reviewed publication. This also I will mention in the subsequent slide. Using statistical analysis for percentiles, including percentiles, MIC 50, MIC 90 to evaluate this data. iCarrot results within the antibiograms of urinary tract, only urinary tract, not others. And defining the antibiogram percentage susceptible thresholds related to empiric therapy decision. So I mentioned this previously. More than 80% would be your first, line of options for empiric therapy decision making. So this is that example where you have again a blood culture. You know that there is a gram-negative bacillus, and you have, let's say, a molecular platform at your level. For example, I have BCID panels with me on BioFire, so I can run the blood culture, and with the BCID panel, I will come to know that this is E. coli and maybe this is XDR, or this is Klebsiella and maybe this is NDM or OXA producing, and this E. coli is NDM or OXA producing, or both producing. So this is our data for about a year, where again, as you see, we have more carbapenem resistant bugs. Sorry, we had more non-carbapenem resistant bugs, because this is in general we have not taken it HA or community, and we have for whatever carbapenem resistant organisms, Klebsiella is the most common organism, followed by E. coli and Pseudomonas. And for our Klebsiella, we know that they are 90% NDM producers. And if I were to look at ceftazidime, avibactam, and aztreonam, we see almost 100% synergy over here. And we know that also ceftazidime, avibactam is 100% susceptible to organisms which are either KPC or OXA. They don't work for NDM. Okay. So that is all for gram negatives. Now here for gram positives, again, if you see this is very, very small data coming out of our BCID panels. But for staph, we found that, 50% are MSSA and MRSA. And for vancomycin resistance, we don't see that in Enterococcus faecalis, but we've seen about 3 cases in Enterococcus faecium, which is again a known fact. So this kind of data from resistance genes can also be added to your antibiograms, and this is what the M39 recent edition mentions. So in your AMSP, it could be used for prior authorization, or it could also be, this information can be used for prospective audit and real-time feedback. So audit of compliance to your antibiotic policy can be done, and that audit feedback can be given to whichever area that you are doing audit. Okay, then what about peer-reviewed publication? These are all aspects that M39 has actually covered. So M39 gives guidance to include in each section how this information can be included in every section of any peer-reviewed publication, which comprises of the introduction, materials and methods, results and discussion. And all of this is basically to ensure that your data is good and it can be compared across studies. Otherwise, meaning reproducibility becomes an issue, and therefore data comparison also becomes an issue. So exactly what needs to be given in the materials and method section is very well defined by M39. Okay, so these were some of my, okay. So my key takeaways are basically that antibiograms play a very important role in patient management as well as the antibiotic stewardship policy. We stick to M39 guidance for preparing antibiograms, but you can have, charts of lesser numbers of organisms, as I have shown you, just to get an idea of, oh, okay, what is predominant. But when you are preparing your antibiogram for your policy, then ensure that you stick to the M39 guidance, which means that you need to have minimum 30 isolates. You need to have first isolates only. You don't include any kind of surveillance isolates. And you can add resistance marker data if you have PCR panels with you. And you could take more than 1 year of data also if that number 30 is not reaching. Use enhanced and routine antibiograms based upon your needs, the needs of your setting. And 1 year data I've already mentioned. And I've been doing it for a really long time, doing manually. It's a Herculean task, takes a lot of time. Besides, data validation and accuracy become a problem when you do it manually through just Excel sheets. So this software has really helped us. I'm sure there are many softwares which can actually get this data out. It really makes life much more easier if you have a software backed solution for doing this kind of data extraction and analytics. And that is precisely the reason why the antimicrobial management team has an IT person as a essential member of the team, because such kind of complex data analytics, they can really help us with getting them very, very quickly. So with that, I'd like to thank you all for your patient hearing. And if there are any questions or queries or any points or comments to be made, please go ahead. Thank you.
Yeah, thank you so much for the wonderful information, ma'am. This is a really unpractical session regarding preparing and how to understand this antibiogram. I really thank from our side, behalf of FCPI, for taking your time and giving a wonderful session. There are few queries. Can I go ahead, ma'am? Yeah. There is one query. They are mentioning like if it is the setup or tertiary hospital where the antibiogram and this AMSP they are implementing for the first time. What is the initial step and how to start as a small?
So I think the antibiogram should be the first step because it's the lowest hanging fruit. Now, if you, whether you have, since it's a tertiary care, I would expect you would have a microbiology laboratory. Okay. So get in touch with your microbiology team and see how you can get this information. So that is why M39 mentions from where all you can get information. Best would be to get it from the instrument if you have an instrument. If you don't have that, then maybe your LIS, where you could capture data. The other thing some people use, so when I was in KEM, we used to put all our data into WhoNet, and WhoNet we know is a free software. Just that you need to put all that data, so you need someone to put that data in.
Yes.
So if that is available, that's also an excellent resource to get antibiogram. We used to get our antibiograms in KEM through the WhoNet software only. As residents, we would add data, and then that data would be given to surgery department, the medicine department, the respiratory unit, and so on. So this is really a low hanging fruit. ये बहुत easy है करने का, and it can easily be done. So get in touch with your microbiology team, discuss with them from where you can get this information based upon your bed strength. See, I am also a tertiary care institution, but my bed strength is only about 250 beds. So I possibly need more number of, much more time to get that number 30. okay, for certain specimens like respiratory specimens. But if there is a tertiary care institution which is 1,000 beds, they might achieve it in 1,000, sorry, in 6 months, you
Yeah.
know. So that number 30 is very important. So I think it's very
Yes.
easy to initiate with your antibiogram.
Understood. Thank you, ma'am. The second question is, if there are two samples from a same patient and one is indicating one pathogen, another one is indicating another pathogen, how to differentiate the true one and what to consider? As only like one sample you are saying to consider. So how to differentiate or how to sort out this issue?
So find out which is first,
Okay.
chronologically first,
Yeah.
that will be taken.
So first infection site need to be considered as a primary
Yes,
sample.
yes.
Okay. If both blood and some an infection site both are same, ma'am, then
So whatever comes as your
okay.
first samples will be taken. Suppose that 2 days later on you send one more urine sample or one more blood culture and that also grows the same, that is not to be taken. The first isolates are to be taken.
Yes, yes, very clear, very clear. And same with the next one. As you mentioned, first line therapy, second line therapy that you have differentiated in the antibiogram, ma'am. Is it like followed based upon aware classification or any other
So
method?
you
Or
can follow the aware classification. You can follow, see, unfortunately, what I have felt and I have experienced is that India does not have enough drugs to follow the aware classification, particularly
yes,
if you go to the ICU. And with ESBL rates in the community to the tune of 60 to 70% or more, I'm not sure where I can follow the aware classification for my empiric
okay,
therapy. And particularly if you have patients who are elderly. So it all depends upon your scenario. If you can follow aware classification, great. Go ahead, do it.
okay, okay. And next one, also you mentioned in the slides that antifungal related antibiogram need to be prepared. May I know like how you are preparing there and how you started this step and what is the way you are continuing, ma'am?
So identify all the common pathogens. So again, there the number 30 is very important. Okay.
Okay.
So exactly the same things happen. The number 30 is very, very important. So that needs to be done. And you will chart out in the same ways.
Okay. So again, it need to be like location wise, like ICU
You
followed by
can do it. No,
non-ICU.
no, you can have a routine antibiogram which is not location wise. But you
Okay.
can also have, see, Candida will be important where all in the bloodstream,
Yeah.
right? That's the most important place. So, then you can have an enhanced antibiogram based upon your ICU, or if you have a transplant unit, or, so on and so forth. You could have an enhanced antibiogram.
Understood. Understood. And one last query is, ma'am, you are mentioning like if the data, like the requirement of 30 sample is not meeting, we can go retrospectively back.
Yes.
So will that won't affect the other samples susceptibility rates and resistant rates, ma'am?
No, it doesn't actually. It doesn't.
Okay.
It doesn't.
Yeah. Fine.
Because
Fine.
you are taking, when will you encounter this problem? You don't won't encounter this problem in your routine antibiogram. You will
Hmm.
encounter this when you are going for an enhanced antibiogram, let's say respiratory samples. Urine
Okay.
also you will not, urine enhanced also you will not probably encounter, but you will have this problem with your blood culture, with your respiratory samples, where that number 30 you are not getting,
Yeah.
particularly if you're a smaller setting. Okay, so then you need to go behind, and it doesn't change much.
Understood. Understood. Very clear, ma'am. Very clear. Thank you so much for your inputs and for your sharing the knowledge to our with your audience. Thank you so much, ma'am. Thank you so much for your time. Once again, have a nice day.
You too, Dr.
If
Satya,
there are
all
any
of you.
queries, yeah, yeah, please go ahead, ma'am.
Are there queries?
No, no, no. That's it.
Okay, thank you so much. Thank you, all of you. Have a good day. Bye bye.
Yeah, thank you, ma'am.